All right, looks like we're about ready to go. You may remember, if you've been with us before, Dr. Mathew Parry is the Chief of Infectious Diseases at Stamford Health and at Stamford Hospital. He's been playing a really important role in our response to COVID-19. He was educated at the Columbia University College of Physicians and Surgeons, did his residency at Columbia as well as at the University of California, San Francisco, and a fellowship again at Columbia. He's boarded in infectious disease and internal medicine. And he's also just an overall great guy. So we're very glad to have him back. Very glad to have the opportunity to have him answer our questions and give us a bit of an update on what's been happening with our response to COVID-19. So Dr. Parry, without further ado, I'll let you give your update, and then we'll transition into some of the questions that I'm sure we'll have.
Thanks, Matt. It's great to be with you again. I think the last time we spoke, we didn't have any vaccine. We were still in the midst of the pandemic, and now we talk about a light at the end of the tunnel, but I think it's still a long tunnel. But we are making progress, and it's really exciting to have a vaccine that looks very, very effective. At least those two vaccines that are currently approved. We'll talk about those in more detail. So in the spring, when we had a huge amount of COVID, we had 150 patients in the hospital with COVID infection. We had an infection rate of 30% in the testing we were doing. And over a period of 3 to 4 months, we gradually got through that, got into the summer, where our positivity rate had fallen from 30% to a fraction of 1%. The hospital census was close to zero, and in fact, on some days we had no COVID patients in the hospital. We were wearing masks, washing our hands, socially distanced, not traveling. And despite all of that, we had the second wave came back in November, December, and January. We've been seeing test positivity rates between 5 and 10%. Not to the degree that we saw in April and May, but pretty dramatic. We had a hospital census of between 30 and 50 on any given day. Interestingly, the mortality seemed a little lower this time. The patient age was a little lower, and we didn't need as much ICU care. In fact, in April, we had 3 ICUs and a 4th one ready to go. And now we have our single ICU. We haven't needed to expand beyond it. But nevertheless, these patients have been sick, and many of them older, and some of them have not survived. And that's where we are right now. And it's surprising, despite all of these public health measures, we've learned that COVID is a very tough disease. In contrast, influenza and RSV, RSV is another respiratory viral agent which causes pneumonia and bronchitis in infants and young children primarily, but also in adults. We have seen almost nothing of these. We've had, compared to a normal season, and I just looked at the data from the last 4 influenza seasons before this, from September to January, we see 400 cases in that time period of influenza. In this season, we have seen a total of 2 cases and 1 case of RSV compared to hundreds that we would normally see. The message that I get from this is that masking, social distancing, hand washing, not traveling, not gathering is very effective for these other viruses. But this coronavirus is very difficult. It's a highly contagious, durable problem, and this is why we have the pandemic that we have. The other issue in the news, of course, has been these variant strains, these mutations that we know happen with other RNA viruses like influenza, and of course our response to that is to create a new vaccine every year. We weren't quite sure in the spring what COVID was going to do, what this coronavirus was going to do. And it appears that it has begun to mutate, that is, change its RNA, change its structure, and it has become more virulent. Certainly in the United Kingdom strains, the B117 strain that's just been described seems to be 50 to 75% more contagious than the COVID strains that we started out with in April and May. That obviously has created a big problem in the United Kingdom, and I think we should be completely open, rational, and learn from history. We will probably have another surge here before we have a control of this thing. The lack of public health measure impact on COVID tells us one thing: we need a vaccine, or we need therapeutics. There isn't much on the horizon therapeutically that looks promising, but the vaccines I think are going to be our big hope. The two vaccines that have been approved so far, Moderna and Pfizer, the initial trials showed 95% effectiveness, very equivalent results. Both of them required 2 doses, generally well tolerated. The question in the mutation perspective is, will these mutations impact the value of these vaccines, just as mutations impact the value of the influenza vaccine from season to season? The viruses are not strictly comparable, but certainly the analogy is there. You know, what happens with one virus, these RNA viruses do tend to mutate and do change. The virus can't mutate indefinitely because otherwise it will lose its capacity to attach to the cell. So if it mutates too much, it won't cause disease. The hope is that the vaccine will still be good enough to inhibit the virus by the antibody production that it stimulates, and that if the virus changes too much and escapes the antibody, it will also escape the ability to bind to our cells and cause disease. But it's an open book. We'll have to wait and see. The scientists who do this very complicated genomic sequencing will tell us what these viruses look like and whether the vaccines will continue to work, whether our immune systems will continue to resist the virus, and whether we need to make changes in our plans. It's important to realize that the routine tests we do for coronavirus, for the COVID-19, do not detect these mutations. This is very sophisticated stuff. It's not anything that we do at Stamford Hospital. In fact, Yale, I think, is the only place in the state that can do complex sequencing. The State Department of Health does a screening test and then sends the viruses to the CDC for further analysis. So it's very complicated, sophisticated stuff, and we're always a month or two behind the current situation. So by the time we get the virus, we do the sequencing, we find out the results, we're already a month later. So I'm sure these viruses are present in the state of Connecticut to a large extent. We know that we've seen a few cases here. I think the state lab last week said we defined 8 cases. So it's probably many more than that. It's just that we're a month behind. So the vaccines are, as I said, well underway. We started vaccinating in phases. Phase 1A at Stamford Hospital in the middle of December. Phase 1A was the initial prescription from the CDC. And those individuals are patients living in a nursing home and the staff taking care of those patients, hospital healthcare workers, and other healthcare workers who are taking care of patients, who we call patient-facing, and other healthcare workers in the community that are not affiliated necessarily with a hospital, including dentists, physiatrists, social workers, perhaps psychologists, psychiatrists in the community that may be independent. So all of those folks come under phase 1A, and we've been vaccinating them for the last month. We then moved into phase 1B, which is where we are now, and I'm sure you've heard about this. Phase 1B includes individuals age 75 and older, in addition to what's left over from 1A, because there are people in 1A who still haven't been vaccinated, perhaps because they didn't want to be vaccinated, or 1A that have gotten the first dose but are still waiting for that second dose. And I know that's two tracks, really, the nursing home, the long-term care facility track, and then the healthcare provider track. Right now, we're vaccinating people over age 75. And as soon as we reach a reasonable proportion of that group, the state plans to lower the age to 65. So we'd be vaccinating everybody over age 65. Stamford Hospital to date has vaccinated about 12 to 13,000 people. We've given over 15,000 vaccines. Some of those are obviously first plus second dose, and many of them are first dose. We ramped up our old hospital, and we're fortunate to still have that facility. As you know, we have a new hospital, but we kept the old facility. We used it when we had overflow from COVID in the spring, and now we're using the entire second floor as a mass vaccination site, doing up to 1,000 vaccines a day, which is a lot of work. We've had to hire a lot of extra people. The throughput, however, is going very well. Patients are very pleased to be able to get the vaccine. And we schedule the second dose at the time the first dose is given. And we're moving along pretty well. As a parallel to this event, we have seen the number of COVID cases in the last 2 to 3 weeks fall a little bit. The positivity rate in our testing has fallen a bit. And actually, our employee infection rates have fallen as well. You think it's a little bit too early to ascribe that to the vaccine, because we clearly haven't penetrated the mass of the community, so to speak. But I think it's a start, and we're optimistic. And our goal is to get vaccine out ASAP. Our limitation at this point is the amount of vaccine available. We only get X number a month, X number a week. We put in our order every week. We get about 5,000 to 6,000 doses a week, which is enough to do 600, 700, 800 a day, so that we can continue to vaccinate at least those patients that are designated in the particular phase that we're in. But we certainly can ramp up and have plans to ramp up more, working with the city of Stamford in a cooperative way to create an even larger mass vaccination site together with our other community partners, including the community health centers, the other not-for-profits in the community. And there are a number of sites now where vaccines are being given. So with that, I'll kind of just wrap up, and I'm happy to answer any questions about the vaccine and about the trajectory of where we're going. So thank you, Matt.
Thank you, Dr. Parry, for that very helpful update. You know, I'm going to have a couple questions I think are common ones. That's the way we're going to do it. And then hopefully people will be putting their questions in the comments, and then I will read those. For those of you who came in kind of partway in, I will be posting this both to my Facebook page and other social media. And also, I'm going to be sending a recording to TV 79, which is the Darien Public Access television channel. So stay tuned. You should be able to watch this there as well. So a couple of questions I think that are on a lot of people's minds. You mentioned that these strains that have been observed in places like the UK and South Africa, that they're more communicable, that they are easier to transmit. Is there any indication that they are more dangerous or lethal on an individual basis?
Yeah, that's been an item that's appeared in the press. But at the moment, I think the consensus is that they don't appear to be more lethal. They don't appear to be more dangerous. The hospitalization rates are not any higher. Obviously, the number of cases in the hospital are increased because there are more cases in the community, but the rates are not much different. A lot more data obviously needs to come to give you exact numbers, but at the moment, our sense is that the lethality is no worse, that the vaccines still work, but that the contagiousness is significantly more.
Okay, that's great to know. Another question I'm sure you get a lot, and I've just seen in the comments is, are the vaccines safe? What have vaccine reactions been like? What can you say to people about the safety of the vaccine?
Yeah, so there's a lot of questions about that, of course, because these vaccines were so rapidly developed of necessity because of the pandemic. But it was more that the timeline for vaccine development was compressed by cutting out a lot of things that just took a long time traditionally to happen. So I understand the concerns about safety, and clearly we only have 3 to 6 months of follow-up in patients who've been vaccinated. So it's a legitimate and certainly obvious question. The vaccines have very common nuisance side effects. Sore arm is very common after the injection. 80% of people have a sore arm. It lasts 24 hours, rarely needs treatment, and goes away as quickly as it came. For the most part, that is accompanied in maybe 30 to 50% of patients by a little fatigue, maybe a headache, maybe muscle aches. And those, again, are very short-lived, 1 or 2 days. A dose of Tylenol, ibuprofen, if necessary, usually resolves this, and it doesn't go on much longer than 48 hours. When we started out, we thought we better stagger our staff, that, if we had a cardiology unit, we wouldn't want everybody to get vaccinated on the same day because we anticipated people might have to stay home for a day or two after the shot if they were symptomatic and couldn't come to work. That did not happen. We did make attempts to stagger the vaccinations by clinical unit, but we did not see that. We have seen rarely somebody who needs to stay home because of an adverse reaction. The prevalence of what we call serious adverse events, where somebody really does need to stay home, they're sick for a few days, they might even need to call a doctor. That's less than 1%. Probably a little higher than with the flu shot, but I think this is a much different disease, much higher mortality, much worse than influenza for particularly the older population. That these side effects are proportionately greater than influenza vaccine. On the flip side, the older patients tend to have a lower side effect profile than younger patients, which is curious, but that's borne out in both studies, both the Moderna and the Pfizer study. So we've been very pleased about side effects in general. There is one side effect that we do need to mention, because there is one potentially severe side effect. It's called anaphylaxis. Anaphylaxis is a severe allergic reaction that's characterized by sudden onset of low blood pressure, shortness of breath, often swelling, rash, and it can be quite severe. You usually treat it with epinephrine. People carry EpiPens. You're probably familiar with anaphylaxis in the context of a bee sting or a nut allergy. Those kinds of things are much more common in the community. Anaphylaxis is the same basic illness, and we've seen that with both of these vaccines. I personally haven't, fortunately, in the 15,000 people that we vaccinated in Stamford. And the incidence looks like it's between 2 and 5 per million. So this is not something that happens regularly. And most of the patients that develop anaphylaxis have a history of having anaphylaxis in the past, often to an injectable drug. And it turns out that the structure of the vaccines, both Moderna and Pfizer, contain lipid, a nanoparticle which contains the mRNA. That's how it gets into the cell. And those lipids cross-react with other lipids present in other vaccines and other injectable drugs. And that's why this anaphylaxis occurs. Most anaphylaxis that happens from these vaccines occurs within 30 minutes of the shot. So when we have a patient with a history of anaphylaxis to other things, we watch them for 30 minutes. Otherwise, we'd be sending them home after 15 minutes if they felt fine. So we've done that a lot, and we've had no problems so far. But we have EpiPens, and we're prepared for this anaphylaxis because it can occur, but it's exceedingly rare, 3 to 5 per million.
So it sounds like unless you've had, previous allergic reactions to vaccines or anaphylactic reactions that you need to be aware of, the vaccine is extremely safe. Would that be fair to say?
Yes, yes. Obviously, anything can happen, but certainly in terms of statistics, if you exclude everybody with a past history of anaphylaxis, this vaccine is probably no more problematic than an influenza vaccine. Although the nuisance side effects, the arm pain, the headache, the fatigue, probably a little bit higher than the flu shot. And interestingly, fever, which we frequently think of as being a complication of a vaccine, is not very common. The Pfizer, I think, was around 2 to 3%, and Moderna was around 6 to 8%. Those numbers, pretty small. And generally the temperature would be low grade, 100, 100.4. And I mentioned it was a lower frequency in older individuals, but it's also more common when the second dose is given. So we try to explain that to patients that the second dose might be a little more reactive than the first dose, but that's certainly not universal. We've seen people who have a reaction after the first dose and have nothing after the second dose. Anything's possible.
And there's nothing riskier about this vaccine just because it's an mRNA vaccine, is there?
No, it's the mRNA technology is, everybody says it's new. It's not really new. It's been around for 20 years in vaccines that have been developed for other infectious diseases like Ebola virus, in cancer vaccines. There's lots of precedent for this vaccine. It's a new concept to be widely distributed as it's being done now. We've got 20 million doses of these mRNA vaccines administered to date. And so, again, it's not new. That mRNA does one thing. It gets into the cell, tells the cell to make a protein. That protein is a spike protein, which the body recognizes as foreign. And that is the protein that's the business end of the coronavirus. The mRNA disappears. It doesn't get into the nucleus. It stays in the cytoplasm. It is rapidly degraded. It doesn't go anywhere. It doesn't do anything except to ask the cell to make spike protein, which then causes your immune system to develop an antibody, and that's what protects you.
Great. So I've seen a couple of questions about kind of scheduling of different phases. I actually got a briefing from the Department of Health today, along with my colleagues, so I can probably answer a little bit about what we're looking at in terms of that question. I'm sure Dr. Parry will have more detail. The governor has said that hopefully we'll be able to expand the eligibility criteria for the vaccine to include people above the age of 65 in the next week and a half. Our primary impediment right now to vaccinating more people is just, as Dr. Parry said, inadequate supply. We just need the feds to give us more and more vaccine. And actually, Connecticut has been a national leader in terms of how efficiently and effectively we've distributed the vaccine. And Stamford Health has been a big part of that. And I have to give Stamford Health extra credit because I know a number of you had trouble with the VAM system, which is a little unwieldy. And Stamford Health has set up its own portal to schedule appointments, which I know people have found much more easy to handle. Folks beyond the 65 plus, the next groups would be the folks under 65 with one of the 12 comorbidities that's been listed by the CDC as being very serious with COVID-19. And then the other group is frontline essential workers. I know I've gotten a lot of questions about teachers and when they'll be eligible. They're going to be eligible during that group. So after the 65 plus group. The only issue is that next group, the comorbidities under age 65 plus frontline essential workers, it's a big group. So it's unclear at this point whether the state is going to stage that group and put some groups before others within that category. And of course, I will update you as soon as we know more on that subject. One question I would ask you, Dr. Parry, you know, a lot of people have had questions about why we're staging things in the order we are, why 75 plus first, and then 65 plus, and then this next group of frontline / comorbid folks. Why have we staged it that way? What's the medical evidence behind it?
Well, I think, there are two answers to that. The first is, essential workers who are at highest risk of exposure. So in 1A, that's generally healthcare workers and the patients that are at greatest risk of a bad outcome, right? So the older patients are at high risk for hospitalization, for respiratory failure and death, which is why the long-term care facility residents and the staff taking care of them and hospitals and the staff of those hospitals need to be vaccinated up front. First of all, they provide an essential service. They're the ones taking care of these patients, exposed to all the sick patients. And then the older patients who are the sickest, using the most resources with the highest mortality rate. So I think that the phase 1A is the clearest of the groups. In phase 1B, again, age is the single most important indicator of a bad outcome. And so you want to take your highest risk patients, vaccinate them first, realizing that vaccine isn't going to be here on day one, with 500 million doses. So it takes time to vaccinate everybody. So you'll vaccinate your highest risk first, and then the comorbidities obviously are picked based upon the risks: obesity, diabetes, chronic heart disease. I mean, these chronic kidney disease, these are the things that we know are associated with higher risk of mortality. There are socioeconomic risks as well, and we are trying to meet those groups and make sure that high-risk patients, in particular the Hispanic community, the African American community, where the public service industry, where you can't quarantine easily because you live in a household of 4 people or 5 people in a room. Very difficult to quarantine yourself and isolate yourself and do all the things that we talk about as public health measures. So vaccine is very important in mitigating the disease in those individuals, of course. So we need to take that into account, and we've made some efforts to do that in our as we roll out these various phases.
Great. And I've seen some questions about whether this is being recorded. Yes, it is. You will be able to watch the whole thing later if you so choose. Let's see. Has the process for testing changed at all? Are there new tests? Some people have been noticing higher turnaround or quicker turnaround recently. Have there been any advances or changes made to testing?
The PCR test remains the gold standard. And in that sense, things haven't changed very much. What has happened is that the supply of testing materials, reagents, is widely now available. And so we have turnaround times that are very short. Most of our testing is now done in-house. We don't have to send it out to a reference laboratory, which adds another 2 days of turnaround time. So most of our testing is same-day testing. Not all of it, but we've certainly made significant progress. I remember in April when we waited a week to get a test result back, sometimes even longer. That's not the case anymore. There are also rapid tests, antigen tests, which are not as good as the PCR tests, but they do serve a purpose in making a diagnosis of a symptomatic patient quickly. But PCR tests are also quite quick. Those turn around anywhere from 30 minutes to a couple of hours, depending upon the brand.
Great. One issue that people have faced, I think, in terms of, it's not necessarily a Stamford Health issue, but they've just kind of had issues in terms of sometimes scheduling appointments. I know Stamford Health has gone to, once you schedule your first appointment, when you show up, they schedule your second appointment right there, which I think
Absolutely.
is what everybody's supposed to be doing right now.
That was a game changer.
Yeah. So I've had questions where that hasn't been done about what you should do. And then the word I've received from folks at Stamford Health in particular, but talking about everyone in the area, all the providers in the area who can provide vaccine, is just keep trying and looking for appointments, because what happens is some locations haven't gotten a handle as quickly on how much vaccine they're getting per week. And so sometimes they can't put up appointments as soon or as far in advance as other places. So if you keep looking for appointments, chances are you will find them if you're 75 plus at this point. So just keep doing that. Don't try to schedule a first appointment. If you're looking for a second appointment because you didn't schedule one when you were getting your first dose, don't go to the Stamford Health appointment calendar and schedule a first appointment. Keep looking in the VAM system, in the second appointment system to do that.
I will say that we do every day we're releasing new appointments. We assess what happened today. We had, no shows. We had people who came in who registered but really shouldn't have registered because they didn't qualify. They were 65 or they couldn't follow the directions. So we could not vaccinate them. So we had some rejections. We've had people who were double booked, and so we actually had an appointment open up. So we didn't use all the vaccine that we allotted for today. So now we have vaccine we can allot for tomorrow. So we'll open up some new appointments. So as Matt said, keep looking because appointments will appear. And although we prefer if you got your first dose in Norwalk to get your second dose in Norwalk because they were allocated your second dose, if that doesn't work out, we are happy to vaccinate you. And we do have open slots and more open up every day. So just keep looking. The other thing I'll say about the second dose is it doesn't have to be exactly 21 days or 28 days. In fact, there is some evidence that actually pushing that second dose out a bit may actually result in a better immune response, at least for some vaccines. We don't really have good data with Moderna and Pfizer about that, but we feel that up to 6 weeks is really okay. So if you can get that second dose of Moderna at day 28, if you get it on day 35 or day 38, that's perfectly fine. So don't be terribly anxious about the fact that it's not precisely 28 days. You've got time and a little leeway, and slots will be available. Just keep looking.
And the outer boundary on that is you're supposed to do it within 42 days, right?
We say 42 days, but the CDC says even beyond that is not a big problem. But I would recommend, just to be consistent with the recommendations of the manufacturers, that you try to get it within that 6-week period. But if you were to get it at 7 weeks, it would not be a catastrophe, and we would not repeat anything that you've already had. So you would be considered fully vaccinated in that situation.
Okay. And for folks who are, try to get it with your second appointment within the 21 or 28 days, depending on the vaccine you have. Again, as Dr. Parry said, if it's not exactly it's not exactly that date, it's fine. It'll still work. if you're getting to that 42 days and for whatever reason just haven't been able to get the appointment, there's something messed up and you are freaking out, reach out to me in addition to continuing to try to schedule a second appointment. And I will help ensure, along with our providers in the area, and Stamford Health has offered to help with this, we'll ensure that you get your second dose within that time. But again, just keep trying to get that second appointment through the scheduling system. Appointments will pop up, and you don't have to have it exactly on that 21st or 28th day. As long as it's roughly around there and it's within the 42 days, you're good to go. So
we have a call center as well, and so you can call the call center. That call, if you explain the problem, will be routed to one of us, and we can handle that as well. So we'll make sure that you're vaccinated safely.
Perfect. So one thing people have been asking about is, do you have some sort of standby list for those no-shows? What do you do to ensure that you get all the vaccine in a given day into arms?
Yeah, we have a pretty structured system. The first thing we do is we manage the vaccine during the day to not have anything left over. So when we get to be an hour before the end of the day, we look to see how many appointments we expect, how many partially used vials we have, and then we consolidate use so that we empty all the vials, and at the end of the day we're left with one vial, and hopefully that gets used on the patients that are there to get vaccine by the appointment. If we have two people that have appointments and we don't have any open vials, we will reschedule them for the next day. Or if there's another clinic across town, as we had when we were doing a vaccination at Tully, we still are actually, we've actually sent them across town because we have an open station there, but we're closing at Tully. So we do everything we can to use up the vaccine. If there is vaccine left over, we have staff that haven't been vaccinated. We have a short wait list that we have used, and we have inpatients. And our plan is to offer this to inpatients, particularly those that obviously fit the criteria over 75 years of age. So our source of patients to use up those doses are our staff, particularly our newly hired staff who are now vaccinated, and the inpatient population. Those are our primary go-to folks to use up leftover vaccines.
Great. I have a question. So we talked about how late someone can get their second dose of the vaccine. How early is okay to get the second dose?
Well, originally the CDC, through the VAM schedule, allowed you to get it 3 or 4 days before the day that was prescribed, the 21 or 28 days. They've since backed off on that, and they now say you shouldn't get it before the 21 or before the 28 days. So we would support that. On the other hand, anybody that got their second dose a little bit earlier than the 21 or 28 days should not get another dose, and are probably protected just fine.
Okay. Let's see. Seeing what other questions we have here. Will we see, so we've got the Pfizer and the Moderna and Johnson & Johnson coming down the line. Will we see additional vaccines from some of the companies that have been making them abroad? There's the Oxford one, there's the Russian one, the Sputnik one. Do you think we'll be seeing any of those here as well?
I suspect so. Right now it's the AstraZeneca and the Johnson & Johnson that are probably close to FDA submission. If we look at how long it took Pfizer and Moderna to go through that process, we're looking perhaps at J&J and AstraZeneca being available sometime in March. They obviously have their own characteristics. Their response rates are unfortunately not quite as good as the Moderna and Pfizer. They look around 70% protective, but those data haven't really been thoroughly vetted by the FDA yet. And the the data that's been released is really preliminary, so we have to wait and see what the final outcome is and what the recommendations of the American College of Immunization Practices will be. That's the Vaccine Advisory Board of the CDC that decides, where a particular vaccine should be used, what age group, what the regimen should be, whether it's 1 dose or 2 doses, and validates the distance between the 2 doses. So all those recommendations will be forthcoming, and then we'll know how to use the vaccines in conjunction, because it might be a little complicated with 4 different vaccines out there and probably more to come. There are about 30 vaccines in phase 3 trials. And those are the trials that are done right before authorization or approval by the FDA. They're placebo-controlled trials where half the people get saline and half the people get the vaccine, and then you look at outcomes to decide whether the vaccines are effective or not. So 30 vaccines in trials is a formidable number. They probably all won't reach the market, but we're looking at 4 now and probably more to come.
Okay, and I've gotten some questions from people about what they should do in terms of kind of weighing about whether they should be choosing between vaccines or just taking the first available appointment. Right now with the Moderna and the Pfizer, they're basically exactly the same in terms of level of effectiveness. Yes. As we go forward, how should people weigh that decision making? Should they just take the first available appointment for any vaccine? Should they try to prioritize certain vaccines? Should factors about their health play a role?
Yes, I don't know the answer to that question. That's something that really needs a sort of a national recommendation, which will come out of the CDC through the ACIP, as I mentioned. There will be specific recommendations that allow us to strategically recommend one vaccine over another.
Okay. And in your update in the beginning, you talked about how COVID's going to be with us for a while, even with these vaccines, hopefully at a lower level of lethality and a lower level of contagiousness, or I guess transmission. They'll be as contagious as they are, the variants, but hopefully we'll have less transmission.
Right.
So how important is it that folks still abide by the social distancing and masking precautions even after they've been vaccinated?
Well, that's a very interesting question that we really don't have the precise answer to yet. The question about how effective are these vaccines in preventing asymptomatic infection and transmission. We know that these vaccines are great for preventing illness. So if you get vaccinated with the Moderna vaccine or the Pfizer vaccine, you have a 95% chance of not getting COVID. You have almost 100% chance of not getting severe COVID and ending up in a hospital on a ventilator. So they are very good vaccines. But we don't know whether they actually prevent asymptomatic infection, a low-grade process that isn't actually symptomatic. It doesn't produce illness, fever, etc. But there's virus there that might be communicable still. So that question is not answered fully. We do know from preliminary data from Moderna and also from Johnson & Johnson, that there is a decrease of asymptomatic infections. But these trials were not set up to figure that out. They were set up to see whether these vaccines prevented symptomatic infection, hospitalization, death, severe disease, and that they showed clearly. But these more sophisticated outcomes that require viral testing and sophisticated analysis and gene sequencing, et cetera, that's data that we have to build over time, and that will come, but we don't know the answer to that yet. So the answer is you still have to wear a mask, you still have to practice social distancing and all those public health measures, but you've protected yourself from severe illness, hospitalization, respiratory failure by getting the vaccine. That's the number one thing. With enough of this vaccination in the community, we expect there to be herd immunity develop, because although we don't know precisely about transmission yet, but almost certainly there will be over time decreased transmission, and that will lead to herd immunity.
Great. So folks, keep wearing those masks. Keep social distancing, keep washing your hands. No time to let up now. So I had a question. This may be a little, down a rabbit hole, but you mentioned that the virus could theoretically self-annihilate based on vaccination. Is that something that is a reasonable hope to have? Or are we, that's kind of a long shot?
Yeah, I mean, mutations, obviously, some mutations are lethal and the virus will die, but that's not the way evolution works, right? Lethal mutations would make the virus extinct, and the viruses are pretty smart, so they'll mutate in order to reproduce and persist. So I think that that was more of a sort of theoretical option, but probably not practical. And I think that we will see further mutations. Many of them will be inconsequential, but some might impact either communicability or lethality or immunity. That your immunity that you had from the April coronavirus no longer works against the September 2021 coronavirus. Those are questions that are pure conjecture. We'll just have to wait and see what happens.
Okay. There's a question about all the vaccination locations in the area. I got some more information on that today, so I'll be posting more about that when I have a more comprehensive list, and I'll keep you updated on that. Let's see. We've only got a few more minutes with Dr. Parry, so if you have final questions, please get them in. We've answered a lot of these.
I'll just, there's one question that we get a lot from our staff, because a lot of our staff are female, and a lot of our staff are young. And there are always concerns about pregnancy and fertility, and these come up a lot in our population, certainly in our healthcare, our workers. And they're obviously very legitimate questions, particularly with the mRNA concerns. But as I reiterated, the mRNA is a self-limited, non-nuclear, non-replicating synthetic material. It's not live, there's no virus there, it's purely synthetic, and it does its job, and that's it. There is no evidence that fertility or pregnancy or lactation is adversely affected by this vaccine. In fact, we know that pregnancy is a risk factor for poor outcomes with COVID-19, particularly late pregnancy. And so the American College of Obstetricians and Gynecologists and our obstetrical staff strongly recommends these vaccines for pregnancy. There is no formal recommendation, however, because these individuals were not entered in the clinical trials. However, as part of the vaccination program that we are currently in the middle of, there is a little app that is given to patients to link up to. It's called vSafe, and it's an app you can put on your phone, and it links to the CDC. And every day in the first week, it sends you a little message and says, how are you feeling? And asks you some questions. And then after a week, it does it every week. And it wants to know how you're feeling. And I still get it once a week, asking how I feel. And it's been, a month and a half since I got my vaccine. And all of that data is gathered to assess safety. There are 15,000 pregnant women enrolled in vSafe already. So we will have more data with time, particularly in respect to pregnancy. Right now, there's no concern that there are any adverse events. And in fact, there is beneficial effect, because if you prevent COVID in pregnancy, then you can save a life. or 2 lives. So we would certainly encourage anybody who's pregnant and thinking about the vaccine to talk to their obstetrician, and certainly think about it, because you can benefit from this vaccine, particularly in later pregnancy.
Great. And the timeline projected for the 60 below 65 with comorbidities is right now predicted to be, for eligibility to be end of February, beginning of March. You know, we're a little behind our original schedule, but hopefully the vaccine production and distribution will speed up. I will post a link to the sign up, both to all the both VAMS and the Stamford system, and the phone number. If you really just kind of get to the end of your rope and you can't figure it out, you can call 211 and they will help you. Let's see. I think we've really answered pretty much all the questions. I can't tell you when Stamford kids will be going back to school. I think that had a significant bit to do with the fact that there was the spike we were seeing around the holidays that subsided somewhat, but we're still at a relatively high rate of positivity. It's going down, but we haven't really gotten back to our previous very low state. So remains to be seen, and I don't make that decision. So we'll have to see what superintendent and other officials at the city say about that. Let's see if there's any more. Oh, could you, Dr. Parry, I know we're reaching the end of your time, the limit of your time, but could you explain the concept of herd immunity to folks out there? I think there's some confusion.
Yes. Herd immunity is, it's a term that's criticized a lot, because herd immunity is defined by a herd. And it came out of the veterinary literature. A herd is a defined group of animals that's isolated. You know, it's one herd. People aren't quite like that, because there's always people coming and going. So there's no defined herd, except perhaps by country. But even there, you know, you've got people coming and going. So your herd isn't a discrete thing. But the concept is that if you immunize enough people, the virus won't have enough hosts to continue to spread to. And once you get to 70 to 80%, you are felt to be at the threshold of herd immunity, where the immunity in the 80% protects the other 20% who have not been vaccinated. And that's the concept.
Okay,
but
so
we're obviously a long way from that 70 to 80%. I believe in Connecticut now we are around 6 to 7%. That obviously should continue to grow. But it's important that we address vaccine hesitancy, because if only 50% of the population is interested in taking the vaccine, we may never get to a critical level of herd immunity, which is not where we want to be from a public health perspective. So I'm hoping that the more people that take the vaccine, the more others are encouraged to get vaccine and realize that this is a safe and effective vaccine and will allow people to travel and get back to relatively normal life, and it's a good thing to do, and that we'll get to a higher level eventually, but perhaps not until the fall, or perhaps even later. But again, we do need to address vaccine hesitancy and reassure everybody and give them the facts and help people make the best decision.
all right, folks. I want to say a big thank you to Dr. Parry for giving us so much of his time and his expertise. I know this has been tremendously helpful for me in understanding what's been going on and what we've been doing with COVID-19. And I know that everyone who's watched this presentation would agree. So thank you for spelling everything out for us. You know, to everyone out there, I my message continues. Please, please, please continue to be conscientious about each other, continue to social distance, continue to wash your hands, continue to wear a mask, and continue not to engage in large gatherings. You know, that's one of the reasons why we had the spike over the holidays, is because people were traveling, they were around family. And I know that you want to do that. It's really difficult not to, but it's really important that you stay with your family unit, not engage in unmasked gatherings inside. I know we have the Super Bowl coming up. You're probably tempted to have a Super Bowl party, but make it a Super Bowl party just with your household, not with anyone else. So please continue to take care of each other, continue to listen to the scientists, to the doctors, to the public health professionals like Dr. Parry, and we'll get through this. But we don't want to take any risks. We don't want to give up now. We've made too much progress. We've come too much far. We have too many tools now to fight this disease to give up and to allow more people to get sick and possibly die. So if you have any questions, please don't hesitate to reach out to me. I'm hopeful that we'll be able to do another of these in the near future once we have a little more information. And I'll try to make sure that I keep you updated at all times with all the information that I have about vaccine access, especially, but all what we're learning about what's going on in the state with COVID-19. So thank you to everyone who watched. Thank you to everyone who will watch later. Thank you, Dr. Parry. And everyone have a good night.
Thanks, Matt. It's always a pleasure. Good night.